Hello, my name is Jason, and I'm the primary instructor for the SI course. What I want to talk about today is that patient that keeps coming in with that stubborn upslip. It could either be a stubborn upslip, or truthfully, it could even be a pelvic rotation that either isn't fully correcting, or you correct it but it just keeps coming back. What are some things that we can do to address that? If you've taken the course, we've talked about pubic dysfunctions and how pubic dysfunctions and upslips lock up the pelvis. They just lock up the pelvis. So whether you're seeing somebody for low back pain, hip pain, knee pain, back pain, lots of different things. If there's pelvic involvement, pubic dysfunctions and upslips will lock everything up and can be hard to correct sometimes. So oftentimes, if that's the case that's going on, oftentimes there's a pubic dysfunction that is driving everything. Now, there's lots of reasons why you may not want to palpate the pubes with this particular patient. Maybe it's because it's your first time seeing them. Maybe it's you just get some weird vibes, to be honest. Who knows? But you just don't feel appropriate palpating them. You can still do the techniques and use test, treat, retest to see if you get the desired effect out of it. I have a perfect example. Just 2 or 3 days ago, I had a patient come in that I had not seen before and was dealing with low back pain, and I could tell he had an upslip on this one side, and I could tell from the notes that it had been addressed multiple times. And I know that oftentimes it's being driven by a pubic dysfunction. But I didn't want to just jump into palpating pubes with this complete stranger of mine. So instead, what I did, if I'm going to demonstrate this on her right side, if her right side is looking like either she has an upslip or maybe she looks like she has a posterior pelvic rotation, I don't know. If it's an upslip, then everything is up, right? So the pubic ramus is up. So if I want to correct it, I would bring her involved leg down. Wherever I want something to go is where I'm going to place it. So if the innominate is up, I want to bring it down. I'm going to bring her involved leg down. I would bring the opposite leg up, taking up whatever tissue slack is available there, okay? From here, I can use a cross-arm technique here, where I'm going to facilitate her adductors. I'm going to have her pull up and in with her right leg and push down and in with her left leg here. But the most important part is facilitating the adduction. She's going to automatically flex. She's going to automatically extend. What I need is to get her to adduct, okay? So from here, again, I just bring the uninvolved leg up to whatever tissue slack is available there. And then I'm going to have her squeeze both in. I want to be on the adductors, so I'm on distal adductors here. I'm going to have you squeeze your knees together. Squeeze in. 6, 5, 4, 3, 2, 1, and relax. Okay? We just gained some motion there. I just take up the slack that we just gained here. And again, I'll repeat the same thing. Squeeze in. 6, 5, 4, 3, 2, 1, and relax. Okay? She relaxes. We just gained some motion. So I'm going to, again, increase motion on the side. I'm treating this side, but I'm just taking up the slack on this other side. It's one complete ring, one complete system. So if I take up the slack on this side, it's going to have the same effect over here. So squeeze both in. 6, 5, 4, 3, 2, 1, and relax. Okay? So if they have this stubborn upslip, if the innominate is up, you want to bring the involved leg down. So the involved leg would be down, the right leg would be down in this case, and the uninvolved leg would be up. What if they have a stubborn anterior pelvic rotation? Okay? With an anterior pelvic rotation, the pubic ramus would likely be inferior. So now to correct it, I would want it to go up. So I would simply just take the involved leg, again, if it's the right side that's rotated anterior, I would just bring the right side up, taking up the tissue slack here, leaving the uninvolved side down, and I would still use the adductors here. However you want to position yourself, I could go over to the other side and do the exact same technique. I could also sit here and have her squeeze her knees together this way, okay? As long as you have the leg in the position that you want it to go, and you're using the adductors on both sides, you'll get the correction that you're looking for.